I'd like to welcome everybody to the Faculty of Surgical Trainers programme, and welcome to everybody joining us today. So the theme of the meeting today is the new surgical curriculum, opportunities, challenges and impacts so far. And I'm going to kick off by asking our first speaker, Mr. Keith Jones, who's a vascular surgeon based in London, and he is the ICP surgical lead, and Keith and myself battled together in the intercollegiate exam. So Keith, we're delighted to have you today and thank you very much for joining us. I know you're on call and you have to leave before the end of the session, so thank you.
Thanks very much. I'm just going to screen share. All right, hopefully everyone can see my
yes,
screen.
We can.
Excellent. Okay, so what I was going to talk to you today to talk about the rollout of the new curriculum and issues what went well and what we could do better. You say I'm a vascular surgeon from Frimley, just south of London. Just a little bit in relation to give a guide of my history is that as well as being a consultant vascular surgeon, I am the surgical director of the Iacp. I'm also chair of the Vascular Society Education and Training Committee, and I was also the curriculum lead. So I come to the curriculum different angles because I actually was the author of the present 2021 vascular curriculum before I became the ICP director. And as I say, I'm a JCIE examiner, so see the importance of the curriculum at the end of training. So the new curriculum arrived for yourselves in July of this year, and for the rest of the ICP participants in August, although when people transitioned was obviously a point for discussion and remains so, and would be one of the things that, as I'll allude to, that we may have done differently of different iterations. So for the new curriculum, there was a lot of work done on the ISCP in relation to access. All the new curricula are available from the front page of the ISCP. We are aware that many of you, when you go to this page, doesn't stay there very long, because if you have an automatic login, it'll take you straight into the ICP. But from this front page, the top carousel, you can link to all the curriculum information required is available on the front sheet page of the ICP, and therefore you don't even have to access and log in. We at the JCIE, or so JCST, produced a lot of video support with lots of information prior to and during go live. So these pop-up videos are embedded in the ICP now. So an introduction to the MCR, the generic professional capabilities and the capabilities in practice, which are, as hopefully you do know, are significant components of the new 2021 curricula. These are the components of the multiple consultant report, and prior to go live there was lots of access to the trial MCR. Whilst not wanting to create confusion, the trial MCR is still available from your dashboard on the ICP for utilisation for trainees that may yet to have transitions. And we're going to keep it there until the final transition date arrives, which is in 2023, although we may debate taking it down if it, as at the moment, does cause a little bit of confusion with people doing the trial MCR rather than that one embedded in the ICP. We did a lot of champions training events. We did two particular events for Ireland, both trainees and trainers, and we did these UK-wide, and we certainly at JCST felt that we had covered a large number of champions to be able to take the information back to their locale and specialties. That may not have been as successful as we thought, and we're likely to repeat a lot of the information now. What we aim to do for those webinars was to provide the rationale for the change and be able to familiarise people with the curriculum and the assessment system. By that we meant that the multiple consultant report, and work through some examples and hopefully utilise that, give the expert knowledge to be taken back to the areas, so improve the local implementation. Our data now would suggest that, and I'll come to this in a bit, that whilst transition has been relatively successful, the pickup from the MCR still needs a lot of work. I have run many of these Ask Keith events and will continue to do so and create some more dates for this. This was essentially me going live on a Friday morning and available to answer any questions that related to the new curriculum and anything in relation to the process, and that's of all specialties as well. And we've recorded all the frequently asked questions in relation to this. There's a lot of work done on the graphics of the Iacp prior to go live, so making it more user friendly, and I hope many people noticed this. One of the big changes related to the phases of the training pathway. And that may be a little confusing, but essentially core surgical training is phase 1. Phase 2 is what you would see in old description being ST3 to ST6, but you know that it's indicative 4 years. And one of the good things about the new curricula is that they are competency based against higher level outcomes, and therefore you can show that you're passing through at a quicker rate. Then you could move out of phase 2 before the indicative 4 years. The indicative is at the time we felt that it would take an average trainee, and then indicative phase 3, indicative 2 years. There is some variations for that, see, away from the 6 years for OMFS and urology, just because of the start time being earlier. So in relation to the new curriculum, what were the key changes from a trainee perspective when it went live on the 4th of August? And obviously that was the UK date. I know that you went live in Ireland at the beginning of July. Well, it's outcomes based, so higher level outcomes. That higher level, and which will be reiterated time and time again, is that of a day one consultant. For the trainees, you're able to progress at your own rate, and you'll be assessed through the multiple consultant report. The judgment of your supervisors is key to the assessment. So then it's their professional judgment within that multiple consultant report, and that undoubtedly is a change, although it's the formalization of what was the process that many supervisors were undertaking anyway, but weren't able to express other than through the work-based assessments. So there was the introduction of the capabilities in practice and the indicative of the endpoint of training based on supervision levels related to day one consultant. They had equal weighting with the generic professional capabilities, which were designed in the curricula by the GMC and the Academy of Medical Royal Colleges. And there are all the descriptors were designed by that route as well. It's very important within the curricula that self-assessment is undertaken, and that forms part of the feedback process in relation to the MCR to allow to a trainee to be able to match their thought process of where they stand in their training pathway against that of their supervisors. The learning agreement focuses on the outcomes of the multiple consultant reports, and therefore that does lend itself to much more targeted development through the portfolio and the curriculum, and mean that trainees may well reach the end point earlier, or with greater confidence. The work-based assessments, the numbers were reduced and they were rebalanced, and they're now very focused. The majority aimed at the index procedures. As I say, that training was based into 3 phases. So the in relation to transition, as mentioned earlier, you would transition to a new curriculum if starting at core at the start of your new training levels, except if you were entering CT2 and you were decoupled, or if you're in the final year of training. Trainees who are less than full-time would remain on the previous curriculum until they transition to the next training level. That has generated quite a few questions, just answered one on my phone just prior to coming on to speak, to determine when the trainee would move over. But essentially, you would transition at the start of your next learning agreement. So the vast majority of people should have transitioned by this point. There may be a group that are doing out in research that when they come back in from the research and start a new clinical learning agreement, they will then transition. For CSER, the non-training grades application to the specialist register, the evaluation will be against the new curriculum, or can be, although there is this 2-year period until August of 2023, at where you can still apply against the old curricula. That standpoint or point in time in 23 is when trainees should have transitioned. Pre-transition, I would have suggested that all trainees ensure that their ICP was up to date, undertaken detailed self-assessment and a gap analysis. And so the best way to do that was by the self-assessment, and that would determine as well the gaps caused by COVID. We often asked about the work-based assessments that have been undertaken prior to August 2020, when the chart that showed work-based assessments required for certification had gone live. And it was sensible for any trainee to summarise all those work-based assessments they'd undertaken, because they won't be lost in their portfolio, but it does make it easier for those to be presented at their next ARCP or their objective setting meeting. And it was very important at the point of transition, since it's all happened within COVID, that the objectives of the learning agreement ensured that you could catch up the training time. So when going to set up your learning agreement, a trainee you would have been asked, do you want to switch to the 2021 curriculum? And as I say, the vast majority of people should have gone yes, and then that would be indicated by a purple box on your ISCP with the 2021 in it. I think if we were looking to do this again, we may have mandated that everyone just switched over to the new curriculum, and there had to be a reason for opting out. May have been a better way to do it, but there was certainly design issues related to why we had to do it this way round. But undoubtedly there has been some confusion for some people related to transition. So it definitely is on the list of the things that I think we could have done a little bit better. As I say, the trial MCR still exists, but it has trial written all over it in a watermark to prevent people using it, because the problem now, I mean using it live for trainees, is that once completed and signed off, it's not saved. It was designed to get people used to the process and be able to practice it, which is why it's still been retained. But again, that may be something that we look at differently if we're going to remove it to stop any ongoing usage instead of the process embedded in the ICP. For the MCR self-assessment is one of the very important aspects of the new curriculum. The trainees, it's the same as the MCR. You therefore encourage it to be undertaken for prior to the midpoint learning agreement. It does need to be undertaken prior to the final learning agreement meeting. The importance of it is that it involves the utilisation of reflection, honesty, the understanding of your own competence levels in both clinical and professional capacities, and own strengths and weaknesses, and the ability to therefore identify and agree with your supervisors what your training needs are. And certainly we provided online guidance to help in relation to this and show where that embedded within the assessment system, which, other than the introduction of the MCR and the reorganisation of the work-based assessments to mainly PBAs, and then case-based discussions and cases related to the critical conditions, that the process of those assessment then lined up to provide a educational supervisor's report, and then that linked into your ARCPs. We hope we've shown clearly about where the progress goes through the learning agreement. The focus has been for us very much to ensure that the MCRs have been undertaken, and to ensure that the midpoint ones have been undertaken and signed off prior to the midpoint learning agreement. Because again, because of the setup of the ICP, unfortunately, if they're not done in that order, the MCR is lost and not accessible. It's not possible for that to occur in the end point, because the final MCR is mandatory, and therefore you can't undertake the final sign-off meeting until the final MCR has been signed off. I just make that point about entrustment. This is very much part of the assessment system in the new curriculum. So the entrustment values as supervisors to determine what activities and to what level we are comfortable with the trainees undertaking, and therefore that shows that their abilities with respect to supervision, to actually have that understood and expressed within the MCR, I think is probably one of our greatest challenges, people to get comfortable with it. But certainly we're finding very positive feedback, mainly from the feedback from trainees, in relation to when they have their discussion post the MCR and learning agreement with their supervisors, to the understanding of entrustment. So that, again, I think this is something that will evolve as people are more used to the curriculum. So the MCR setup has created a little confusion as people get used to it. The lead clinical supervisor is a new role. The lead clinical supervisor is nominated by the trainee when setting up their placement. It can be ratified with their educational supervisor, and then you can choose who your clinical supervisors are. That lead clinical supervisor will then be notified through their ISCP that they can organise an MCR, and the MCR multiple consult reports should take place face to face, either in departmental meetings, local faculty groups, or online, but involves the clinical supervisors and the lead clinical supervisor. Must be more than two, and anyone that is unable to take part face to face is able to feed back into the meeting in the following 2 weeks. That 2-week feedback, again, is something that we may look at, because it's created a degree of a time pressure, and to say maybe a problem with the midpoint, because of it causes the delay in the ability to undertake the learning agreement. It is very important within the whole MCR process. In fact, I think the most important aspect is that there is a dedicated feedback session between the trainee and their lead clinical supervisor, or a nominated other supervisor, that may be the AES. But it's very important for feedback sessions to take place, because then that creates the focus ongoing for the training. So hopefully you're all aware of what the MCR looks like. Split into generic professional capabilities in practice, based on the latter, based on supervision levels. I always like to express the importance of looking for the education supervisor prior to sign off, and looking at GPCs 6 to 9. And whilst the clinical supervisors have concentrated on the clinical aspects as relevant to the trainee, these GPC components may have some evidence in the portfolio, and the AS should definitely reference those when they sign off the report. It is helpful for the lead clinical supervisor to be aware of what the global objectives for the trainee are, and that allows focus in relation to the progression through the syllabus, and certainly focus of what the MCR is looking at for the trainee in that placement. The timings of the MCR are very important in relation to informing the learning agreements and how those link into the ARCPs, and that again is a significant challenge to ensure the ARCP timings are at appropriate levels, and various different workarounds have been achieved to ensure that, such as having the ARCP slightly out of sync, so they definitely follow one of the MCRs rather than being just in 1 month a year, when it creates a sort of virtual foreshortening of the placement, because we're aware that once the ARCP has taken place, trainees tend not to undertake any ICP activity for the remainder of the placement. Just going through to show, if you're aware of the 9 domains of the generic professional capabilities, each of which have descriptors that can be utilised within the MCR and the feedback. And the capabilities in practice are, for the majority of surgical specialties, there are 5: the management of the outpatient clinic, the inpatients, then the emergency take, management of the operating list, which is global, it's not just the technical aspects, and multidisciplinary working. The supervision level is based on that of a day 1 consultant, and that is their higher level outcome. We note that there is level 5, which shows that people are able to act beyond the level expected at day 1 consultants, essentially recognising excellence. Within the CIPs, if you have been marked as anything less than 4, you will need to utilise the descriptors and show points for development, but you can also show evidence of what the trainees do really well or excellence, and again that can be replicated within the self-assessment. So what could we do better? It was a question that I was asked to address. Could we have made transition automatic? You see this percentage chart. So for my own specialty, vascular surgery, we've got 87% of transition of people that were done appropriately. You'll note that in cardiothoracics, the transitions have not been as high. And realistically, looking at the numbers of trainees that are out of training doing, let's say, OOP-Rs or different out of training program experiences, these percentage levels should all be over 90%. So yes, I think we could have done transition and differently, and we wonder whether we should have just made it automatic and you would have opted out, and that's certainly something that we would look to consider for any future changes. In relation to the WAs for certification, I think this is an excellent chart. It makes it much easier, certainly really easier as a supervisor to assess when undertaking the ARCPs, looking at progression, making sure all the critical conditions have been covered. But certainly we think should have been clearer about the historical ICP evidence. So we answered the questions when asked on repeated occasions, which suggests to me that our upfront guidance should have been clearer over that. And ongoing, one of the many questions that we have relates to the previous checklists that were utilised for the curriculum, often based around ARCP levels at year 4 and year 6. Those checklists are no longer allowed by the regulating bodies, and I suspect we had underestimated what had become the reliance on those checklists, and therefore we're going back through and showing examples and guidance of what the requirements are. Part of that, and what is very important of these, is this chart about critical progression points, and we should highlight this to trainees and trainers. And certainly before doing any MCR with my colleagues, I will reference this chart to say, well, we're talking about a trainee who is in phase 2, and therefore these are the levels that we would expect them to be at the end of that phase, and base any comments that we make within the multiple consult report against that level. And I think that it is something that comparison and this utilization chart is something that we could have described better within the training, and something that we should highlight greatly now, because it certainly makes it a lot easier undertaking the MCR. In relation to the progression and learning agreement, I've mentioned that the 2-week reflection post the MCR has caused a little bit of confusion and created the problem with the timeline. In reflection, we think a traffic light system would probably be useful. The question is how easy or difficult that is to program into the Iacp. It would take quite a long time for that to be embedded in. There's a traffic light system for usage of the Iacp, but we did feel that it might certainly help TPDs drive MCR numbers. And again, we perhaps ought to be doing some focused training sessions for TPDs related to their utilisation of the new curricula and the MCR. We are concerned that some MCRs may have been lost. So I'll just moving through to show there was some MCR feedback for the trainee, obviously very important, and the fact it's comprehensive, it shows progression of history. The time commitment should have been offset against the less work-based activities, and hopefully it's embedded in people's time they get for being educational supervisors. Finally, it is very important that the RCP is taking place after a relevant MCR, and that can be referenced, and we are working to get those timings a bit better. So overall, I'll just leave you with what I see as the benefits of the new curricula. There are high-level outcomes that reflect the job of a day one consultant, so it ensures that you as a trainee are ready for independent practice. The generic professional capabilities are really important to providing the professional skills generic to all medical disciplines, and therefore address the problems that were previously seen in some fitness to practice cases. And it is vitally important that we're now using the professional judgment of the supervisors within the assessment system, and that subsequent to that, the trainees get very focused and meaningful feedback, which allows them to move through the system quickly and also to demonstrate excellence. So thank you very much.
Keith, thank you very much for your very comprehensive talk. Now, I know, as I say, you have to leave probably before the end of the meeting, but you're on call. Is there any question?
Oh, well, I can stay for the just for the Q&A.
Okay, that's great. Thank you. So we'll move on then to our next speaker, who is Ms Rowan Sheehan, who is the Programme Director for Trauma and Orthopaedics. And Owen is going to speak on practical tips and issues from a trainer's perspective. Owen?
Great, thanks very much. Bridget, you can all hear me there. I'll screen share here if that's okay. Let's see, there we go. Okay, everyone see that there. Okay, apologies now, I'll just flick up. Okay, so you can all see that there. Owen Sheehan is my name. Thanks, Bridget, for inviting me along to speak at the faculty, which is an important faculty in the college because it gives an opportunity for TPDs and people charged with surgical training in the college to discuss and get together from a forum perspective and discuss where we're going and what directions we're taking. And Bridget has chaired that committee for the last couple of years, and I'd like to thank her for that. My name is Owen Sheehan. I'm an orthopedic consultant. I've been the training program director in orthopedics for the last 3 years. Prior to that, I was assistant training program director. And I suppose I give you a perspective from a TPD, but also from a trainer. So I've been asked to speak from a trainer's perspective. And recently we ran our ARCPs. We're slightly out of kilter with everyone else in that most training programs run their ARCPs in June. They run a full year and obviously a changeover. We run ours in January, mainly because we generally sign our people off for exams to sit their exams in the MCQs in June and then the Vivas in November. So they fill into the next cycle in year 5 of their training program. So we're a little out of kilter. So we've had a run through with regard to the MCR. We've had the Ask Keith sessions, and we've done sessions ourselves. Some of them well attended, some of them poorly attended. We've had to heavily rely on Helen Harty, who would be our ISCP liaison person with the college, to try and progress it at our recent ARCP. And the MCR, it's an excellent tool. It just needs to be nuanced. And I suppose you can bring a horse to water as well, as Keith would probably well know, and trying to explaining the nuances of it can be a little bit difficult. So we have trainees in all hospitals around up and down the country. At any one time, we could have trainees in 13, 14, 15 units. So therefore, we're dealing with a large volume of trainees, up to anything up to 60 currently. And we also have up to 80 to 90 trainers to educate with regard to this. With the ISCP platform, you have to road test it. You have to log on and spend half an hour doodling around with it. There's all various little sort of rabbit holes, almost, I describe them as, but there's an awful lot of information on it. And sometimes it can be quite difficult to, separate the wheat from the chaff almost with it. So what a TPD looks for on the ISCP is entirely different to what an AAS or a CS might be looking for on the ISCP platform. So you have to road test sections of it. And obviously certain sections are curtailed. For instance, as TPD, I have access to 62 trainees, their entire systems, their logbooks, their MCRs, everything, their learning agreements going back to their entire training. Whereas an AAS would just have access to their current trainees. We also have mentors in orthopedics. Every person is a mentor, and they're tagged into the CS group. So when MCRs were being piloted and they were looking for lead CSs, some units only have 2 or 3. So you have an AAS and 2 CSs, and the AAS couldn't be the lead CS. So we were automatically in a dilemma. So we just automatically assigned AAS to lead CSs, just to lessen the confusion, so to speak. So we did leave a little bit of it bespoke and at the decision of the individual units to decide who they wanted to allocate or blame for their lead CS role. And then with ISCP, it's interesting, we look at our trainees, and some of our trainees log on twice a day. We have one trainee, I think, logged on 700 times in 1 year. And then we have other trainees who log on twice a year. Obviously, they're logging on for their ARCP and then an end of year rotation for their AAS reports. This is not appropriate at all. And those people generally get ARCP 5s. Again, we liaise with Helen Harty. The MCR trial, Keith did mention it. Road testing it is interesting. It is an interesting, I suppose, between the GPCs and the CIPs, it gives you an interesting compendium, it's tailored to the curriculum and tailored to the capabilities, and the progression metrics is what you're looking for. What do you want to bring? Obviously, and we're all familiar with the consciously competent and unconsciously competent surgeons. We're trying to bring people up through the grades. So from grade 2 to 3, 3A, 3B, 3C to grade 4. Grade 4 is a day 1 consultant, as Keith has pointed out. Ultimately, though, we want to bring them up to a level after their second phase in training, which brings them up to the exam. And we kind of use that as our sort of way. There is waypoints, I know, and there's critical progression points or pinch points that would determine. So those ARCPs are vitally important, and the MCR really feeds into that to see if they've attained progression throughout their training program, certainly for the first 4 years. And in the current climate, as I'll get on to later, with COVID logbooks, there's a little bit of a disconnect between trainers and the program, and with trainees moving units and not getting volumes, not getting as comprehensive exposure as possible. So when Keith mentions the potential to progress or skip a year, I don't really think that's going to be a runner at all, to be quite honest, certainly with the current batch, because all the current batch have known, certainly the ST5s they've just operated entirely in a COVID environment, which is not an ideal teaching environment. The MCR, the interim MCR, a lot of our guys were clicking the interim MCR in November, hoping to get the final MCR done in December. The 2-week lockout absolutely murdered it, basically, because they were entirely dependent on the 2-week lockout. So when it's finally populated and the form is put out to the other CSs for commentary, independent or anonymous commentary, there's a 2-week lockout window. And of course, they were all doing it 2 weeks before Christmas, and lo and behold, it was 2 weeks after. By the time the ARCPs came around, a lot of units, including my own unit, I might add, had no MCRs populated, or they weren't finalized. And the other complaint I had, really, not a complaint, but an observation, is as TPD, I have no master key to get in on the MCRs for the other units. So I can't access what's going on. I don't have a master key to switch it on, progress it, or see whereabouts how many CSs have commented on it. I have no window on that, and I need a window on that, particularly if we're currently, as we are, in a virtual climate. So, as Keith has pointed out, there's a plethora of information on ISCP. There's potential applications for work-based assessments, PBAs, all that type of stuff can be done, and it focuses on all the professional capabilities to consent, interactions in outpatients, inpatients, operative, managing lists, managing acute services, etc. So the lead CS, as I've mentioned before, and then of course grade 4 is a day 1 consultant, and the grades should improve as the people progress through as the trainees progress through the training program. Critical progression points. The exam sign-off is the thing. You have to reach a certain level for exam sign-off, except in operative experience. As you saw, Keith's slide had 2B instead of 3, and the other critical progression points were 3. I was under the impression they were 4. Maybe Keith might clarify that for me. Previously, when we signed people off for the exam, they were to be level commensurate with a day 1 consultant, and we were putting them down as operatively at a day 1 consultant, which is probably incorrect, to be quite honest, because some people still need work, so it hampers some people, and for other people then they may come back easily. And as was happening in our program was that, well, you said I was sit to start as a day 1 consultant when you signed me off for the exam, and now you're saying I have to extend my training for operative experience. So there's a bit of a caveat there in that. So that was slightly rolled back to state that they were, not a day 1 consultant to sit the exam. You don't have to be a day 1 consultant operatively to sit the exam, because it's a continuum, it's a training program, and you do need, on occasion you don't, but most trainees do need the comprehensive 6 years of operative exposure. They can go into the final phase on fellowship, and that's entirely up to themselves, or there's various TIG type fellowships arranged, and they're all above board and perfectly suitable for training, but they are recognized posts. The curriculum is, I suppose, the deadline, a bit like Brexit. The deadline is the 2nd of August 2023, and our ST8s currently are not on the new curriculum. I left it optional to our ST7s whether they choose it or not, but they either chose as a group or not, a bit like Brexit. So they all chose not to go onto the new curriculum. Now, I'm not going to discommode them, to be quite honest, but in all probability, they're not on the new curriculum. But all trainees by 2/8/2023 in trauma and orthopedics will be on the new curriculum, and that's just a I suppose a decision we've made in trauma and orthopedics. Again, the MCR is handy. Our RCSI rep Mark Crowthers advocates the MCR particularly for trainees who aren't performing well, and you can certainly point out small little things like teamwork, and these are all part of the GPCs, and the CIPs are generally how you operate clinically. The general professional capabilities were put in place on advice from the General Medical Council as they were populating generic professional capabilities in practice. And this spans across all disciplines, not just surgery, but it goes into general practice. And also I do know, I mean, maybe keep my comment on that. I do know Max Fax and Plastics in the UK have slightly different slants on their curriculum and on their progression metrics. So that's another perhaps question for Keith that might answer after. I'm getting more questions than now during my talk, Keith, unfortunately, than at the end. this is what I see when I log on. So apologies, we've tried to sanitize it from a GDPR perspective, but we have 59 trainees on our training program. So that's what I see when I log on. I like anyone else, I have to validate work-based assessments, MSS and MCRs on the top right-hand corner here. But then again, I'm not an AES, but I am a CS, so I do work. And I've delegated training program directors. So what delegated training program directors are, we allocate a mentor to a group to go through the ARCPs, to go through the ISCP platform and see if all the metrics are in place. And we use an Excel spreadsheet, and Leah in the office in the RCSI will populate a traffic light system where we have things from e-logbook, is it good, is it up to date, indicative numbers, are they up to date? And this would be prior to MCR, but we have the MCR, MSF, we have their UKITE score, which is the MCQ, the mock MCQ that they do. I'm not sure if the other disciplines have that, but we recommend all our, no, it's voluntary, but we recommend strongly all our trainees do the UKITE, and we look for progression in the UKITE as well. So just, this is my own personal sort of opinion, and this may be shared by trainers. I don't like, it's a bit like Albert Reynolds, I like a one-page summary of everything. So what we have in the initial page of the dashboard when we open it up is the trainee's name, which unfortunately that's not covered there. I don't know if it's covered anyway, Sean won't mind. But certification dates, training numbers, all that type of stuff are there. I don't really need to know GPC numbers, national training numbers. I do need to know their current placement. And the other thing is, an awful lot of people put too many CSs, clinical supervisors. I have clinical supervisors on certain platforms that actually were their clinical supervisors 2 or 3 posts behind. And we put our mentors on as well. And that's another comment about the MCR, populating the CSs who have to sign off or comment on the MCR. Some of the CSs are working in different hospitals, and they're just inadvertently put on or added to it, and they have no idea that they've been added to it, even though they have received email prompts. But then again, I don't have full vision on how exactly the CSs are prompted when the MCR is uploaded for commentary. So that's another thing I don't have sight over. When you scroll through this, you see that you've got learning agreements. Give me a second there. And I suppose the learning agreement is the main thing that we look at, because you've got you've got interim and final learning agreement objectives, and the MCR will go a large way towards populating what the agreement in learning will be for the next rotation or the next 6 months. And again, the MCR and MSF is something we look at a lot in orthopedics. It generally gives us good insight into what kind of insight the trainees have of their own performance compared with what their peer group or what their working colleagues and paramedics and all staff across all disciplines make of them, to be quite honest. And you do have, you obviously have people who would be quite modest, but then you have people who, obviously, I'm sure we have them in every program, who, you know, are to consider themselves absolute rock stars when in actual fact they're not. So it gives us good insight, in fairness, and maybe the self-assessment as well is very good at pre-populating the MCR. It gives us insight into, if someone has insight, it's really easy to deal with someone who's got insight. It's the most difficult trainee I've encountered in my entire time training is the trainee that denies insight or denies, contradicts point blank what you've said, even though you have massive metrics and evidence to support same. Down at the bottom of it there's other evidence. We put mental reports there. We find them actually a good sort of a second guessing of trainees, because some of the mentors will follow the trainee all the way through their training, will get to know them. It's almost like a buddy system, like they have in the Scottish deaneries. So the mentor report is interesting. It's one of the first things I'd look at if there's any issue with the trainee, and look at the mentor report. And I'd call the mentor and say, has the trainee been on to you? Because on occasion, trainers won't call me. Trainees on occasion won't call me or make any kind of contact with me. Even though we do have a trainee representative organization called IOTA in orthopedics, and they do sit on most of our committees with regard to training, and that they give valuable insight, because there's no point introducing something if the trainees are going to point blank say that this is complete rubbish. So we have to have them on board and at the table. And as a colleague of mine used to say, if you're not at the table, you're on the menu. So you have to have all stakeholders aboard. Am I going over time, Bridget? I'm okay?
Even another few minutes, yeah.
Okay. with regard to scrolling through it, there's an awful lot of information on it. And I suppose if when you group it on ISCP, if you group it across the page as opposed to down the page, it makes it just a lot easier for me to click on. And the traffic light system here in the bottom right hand corner certainly does help. And it gives me an idea as to what's up to date, what's not up to date, trainees in active placement, where they are, a nice synopsis of everything. So when someone rings me, I can snap them up quickly and I can see where they are, how they're performing almost immediately. The M surgery system is very good. Dunica has developed this in the college with Sean Tierney, and this is in evolution. So this is very good because this is what I see. If I go into ST4, I see their training number. I'm not really, again, interested in that, but it does give a metric, their name, their post, and how many operations they've done in that current post, how many times how many operations they've logged on in the last 4 weeks, and what their total number in HST is. So I've circled one there, 561. That means that person has done 561 operations in the last 18 months since on the training program. They've assisted 50% and performed 50%. So the conversation there is that they're doing well, their numbers are good, and then I can click on reports and get indicative numbers. So this is a lovely synopsis, a snapshot of all the trainees across a single training year and how the things are going. And it allows me to compare units as well, which is good and bad. Again, our logbooks fell away. This is the drastic metric, and Bridget has seen this as well. You know, there's very little we can do, and I'm sure the UK logbooks have been absolutely catastrophically affected as well. Certainly in orthopedics, elective, it was a dead duck last year, to be honest. So we've had to make changes. We've sort of, in earnest, said no out-of-program experience, out-of-program training only in exceptional circumstances where logbooks are good, no retrospection at all, and critical progression points. There's going to be no one fast-tracked currently in our batches at the moment. There's a little disconnect between trainers, the virtualization. We all look forward to going back to face-to-face at meetings like this, particularly when you're making, I suppose, strategic decisions with regard to trainees and training. You could have 15 people on a virtual Zoom platform, but the one person might have something to say. But if you were in a face-to-face meeting, they could sidle up to you and network with you on over a cup of coffee and explain something to you that they probably wouldn't be comfortable expressing on a Zoom meeting. So Zoom is good, but it has its I suppose it has its failings. Despite electronic conduits, a lot of my trainers are a little bit out there, to be honest, so I'm trying to reach them. Trainees, I'm not going to go into this in too much detail. Trainees are still the same. They're high-performing people. You know, we're taking in surgery, in all across all disciplines of surgery. These are high-performing people. They're easily the top 1-2% of their years coming out of their leaving cert. They've done study medicine. They're high flyers. They're keen and they're educated. And they're basically motivated and keen to get on. So the trainee is the same. It's just, the management of them is just a little bit different. And there's different types of trainees. You want really good trainers to spot the unconscious incompetent person. This is an example, obviously, of someone who works in media with BP, who is obviously not too competent. So you can read that and have a laugh at that. I won't reflect too much on that. This is something the college are introducing, situational judgment tests. It's testing people, psychometric testing to some extent. It's running GP screening in the UK for their interviews. And the HST progress is a 6-year interview, as people keep pointing out to me. And my old boss, God rest him, Dick Rotman in Philadelphia, used to say, always employ people that are better than you, work harder, because then you've less to do, which makes sense. So when we look for trainers, we look for good trainers. We look for good people to follow on from us. Thanks very much.
Thank you, Owen. Thank you very much. So I'm going to move on to our next speaker this morning. I'd like to welcome Michael Flanagan, who is going to give us the trainee perspective on the ICP. Good morning, Michael.
Good morning. I'm just sharing my screen now.
Thanks, Michael. We can see you there.
Great, thank you. Okay, is that sharing okay there?
Yes, we can see it.
Okay, thank you very much. So good morning, Chair, speakers, delegates, for inviting me to speak on this session on the new surgical curriculum. So this morning, I'd like to outline the key changes to the new curriculum from a trainee's perspective and the trainee's perspective on these new methods of assessment. So just to introduce myself, Michael Flanagan's name. I'm the president of the Irish Surgical Training Group. So we're a representative body for surgical trainees that act to represent trainees at all levels, and it's run independently by trainees. We advocate for surgical trainees at meetings with the professional bodies, and we also organise annual events, including our annual ISTG meeting, which is taking place tomorrow. So there have been a number of key changes to the new curriculum, which have been outlined by the previous speakers already, but just to highlight these from the surgical trainees' point of view. So surgical training has now become outcomes-based, and the end of training will now be reached when supervisors agree that a trainee is performing at the level of a day one consultant. The new surgical curriculum is also introducing phased training. So in general surgery, the early specialist registrar years of training focus on the generality of general surgery, including the unselected emergency take, and then following that, the specialist interest phase of training in the later years, producing at the end a general surgeon with a special interest. The generic professional capabilities that we've heard about already, these were developed by the General Medical Council in response to common themes and concerns around doctors' performance and reports from high-profile patient safety inquiries. These are now assessed as part of the multiple consultant report, which we've heard about and which I'll discuss in detail with respect to the trainees' perspective of this. And again, then the capabilities in practice, these are the major areas of development through training to cover everything a day one consultant needs to perform. So integrating knowledge, clinical, professional, and technical skills. So these new assessments, which include the multiple consultant report, the multiple consultant report is an assessment by the clinical supervisors who work with the trainee on a day-to-day basis, assessing them on the high-level outcomes of the curriculum, which namely the generic professional capabilities and the capabilities in practice. So the trainees have a corresponding self-assessment to aid their reflection, as well as discussion with their lead consultant supervisor at the feedback session to see how that correlates with the multiple consultant report. In the new curriculum, there are no longer, as you've heard, there are no longer a minimum number of work-based assessments to be completed in the per training year. Instead, the focus of the work-based assessments is in the key areas of the syllabus, namely the critical conditions and the index procedures, for which WBAs are required to show evidence of competence by the completion of training. So incorporating the 9 generic professional capabilities and the 5 capabilities of practice, the multiple consultant report attributes a global rating or supervision level as recommended by the clinical supervisors. So this meeting, or how this deviates from the previous curriculum, this meeting no longer happens with the trainee present. So, however, as reflected already, the most important part of this is the feedback following the meeting, which is it's provided after the process has taken place. So from a trainee's perspective, in practice, the trainee identifies their lead consultant supervisor before the objective setting meeting of the learning agreement. And then once the learning agreement has been signed off by the trainee, they then can complete their self-assessment, and the lead clinical supervisor receives their multiple consultant report link. All of the clinical supervisors listed on the multiple consultant report need to sign off on the report either after the face-to-face meeting or within the 2-week window. Following this, the assigned educational supervisor receives their notification for sign-off of the multiple consultant report. And then it's at this point that the report is available for the trainees on their portfolio, and the lead clinical supervisor arranges to meet and discuss the feedback from the report along with the trainees' self-assessment. So because this process is driven by the trainer and requires comments on the capabilities in practice and the generic professional competencies, to be populated, the trainee receives a robust assessment from their clinical supervisor. So it's no longer an option for trainees to just submit pre-populated work-based assessments for consultants to validate. It comes direct, it's driven by the trainer. So in an effort to assess how trainees perceive this new method of assessment and their experience with the new curriculum, a survey was circulated to all surgical SPRs in Ireland on their engagement with the Iacp and the new surgical curriculum. So we had 67 respondents across a range of specialties and stages in training. So in total, there are approximately 240 higher surgical trainees. So this is likely a representative sample of the group as a whole. The greatest number of responses came from general surgery and trauma and orthopedics, the two largest groups of trainees. So as Professor Sheehan has stated, the orthopedics cohort are the only specialty so far who have completed their ARCP with the new program. So outside of orthopedics, many of the trainees may not be familiar or may not yet have completed a multiple consultant report yet. And then this was just showing the stages of training from the respondents. So most respondents were in their early years of training. And again, many of those in final years of training have chosen not or are not allowed to switch over to the new curriculum. So as such, there are less respondents in that group. So presenting the results from feedback from trainees, I'd like to highlight the positive results, what trainees feel have been a welcome introduction with the new curriculum, but also to discuss some challenges posed by the new curriculum and the ISE assessment as a whole. So overall, 80% of surgical trainees on higher surgical training thought that the move to an outcomes-based progression was good for surgical training. However, when asked if they felt that the move to an outcomes-based assessment would change the length of training, the majority felt that it would likely have no impact on the length of training, and if anything, it may lengthen it. The survey assessed trainee engagement with the ISCP and the new surgical curriculum, and overall there was a good level of engagement with different aspects of the curriculum. So the majority of trainees had engaged with the learning plan and discussed with their consultant trainer an agreed learning plan. Of those that had completed an MCR and received feedback, 66% of this found this feedback to be helpful. 70% of those had actually read the new curriculum, and the majority, 90%, were aware of the critical conditions in their specialty and the index procedures as outlined by the new curriculum. Again, with regard to interface and usability of the website, 64% felt that it was easy to submit data for assessment on the ISCP website. So when asked with regard to the multiple consultant report, respondents felt that when asked if it was a more accurate reflection of their performance compared to other assessments, the results were somewhat mixed. But the majority felt that, or at least more trainees felt that the MCR was a fair assessment, more so than those that did not. When asked if trainees had completed a self-assessment, 75% had, and of those, only 70% of it didn't find it useful. Now, we didn't ask why trainees did not find it useful, but I would expect that because we're in the process, or that both trainees and trainers are not fully up to date or up to speed and engaged with the new process, I'd expect that once the full process is up and running and trainees are more aware of how to fully utilize the self-assessment in conjunction with the MCR and receive feedback on that from trainers, that this will be of benefit to both trainees and trainers. Trainees felt that in relation to their procedural-based assessments for their index procedures, that the feedback they received from their trainers, that they felt that that was useful in terms of their assessment. However, for the work-based assessments on their critical conditions, the feedback received from other work-based assessments around the critical conditions, they did not find as useful. So when asked if they felt that that their last ARCP, if the majority felt that this was, whether or not they felt that their last ARCP was an accurate reflection of their performance, more so felt that it wasn't an accurate reflection of their performance. However, as we discussed, many trainees on the new curriculum have not had their new ARCP yet. And I suppose this is an opportunity for, there is opportunity for improved satisfaction or perception of the review process among trainees, and hopefully with engagement of trainees and trainers, trainees will have will feel that the new multiple consultant report as part of their ARCP is a better reflection of their performance. Again, discussing about the awareness of the new aspects of the curriculum, only 74% of trainees were aware of the capabilities and practice in their regarding the new curriculum. And again, about approximately a similar number were aware of the generic professional capabilities. And when asked specifically whether or not they felt that these were an important aspect of the trainee assessment, over 50% of it felt that they were an important part of the training aspect, but in terms of the numbers, it does suggest that there needs to be a greater trainee awareness and engagement with the process, so that the trainees are aware of how it is incorporated into the multiple consultant report and can provide a robust reflection of a trainee's assessment and performance. When asked if the trainees were aware of the number of work-based assessments required for certification, approximately 70% were aware that of what work-based assessments were required, and these were namely in the index procedures and the critical conditions. However, as there are no longer a minimum number of work-based assessments needed, looking at the numbers of work-based assessments submitted over the last 6 months would be significantly reduced compared to having on the previous curriculum when there was a mandatory number per training year. So looking then on the training received by trainees on the new curriculum, 62% of respondents attended training on the new curriculum. However, only 45% of these found this training to be helpful. We didn't ask specifically why they did not find this to be helpful, but 56% requested more support from the ISCP on the new curriculum, and 54% felt that training on the curriculum should be mandatory. So when asked if trainees felt that the new curriculum meant that there was less administrative burden, trainees did feel that the new curriculum created an increase in the administrative burden. However, this may likely be due to the new aspect of the training and learning involved, and once trainees are up and running with this, it is likely that the offset of the reduced numbers of WBAs now needed will be offset by what's needed for the creating the learning agreement and the new multiple consultant report. When asked if they felt that trainers were more engaged with the new curriculum, the majority felt that they were not. And again, this may be down to trainees and trainers not being fully engaged yet with the new curriculum. So it'll be interesting to see if we assess or survey the trainee population in another interval, whether or not that this is improved. So overall, we also requested from trainees comments on the new curriculum. Some positive comments were that those that had engaged felt that they had got a very good experience with their trainers in terms of the multiple consultant report and the feedback. And again, alluded to by Professor Sheehan, that there has been excellent support on this from ISCP, specifically from Helen Harty as well. Some negative aspects from the comments were that there wasn't enough buy-in from trainers, that the interface wasn't user-friendly, that an outcomes-based training is unlikely to have an impact on the actual length of time of training, and that now that there's only learning agreements, that it's less of an interaction with trainers. However, as we've discussed, that the most beneficial aspect of the multiple consultant report is the feedback process afterwards. So hopefully with more engagement with trainers and trainees, that this will be effective with more effective buy-in. So in summary, the move to an outcomes-based curriculum has been positive overall. The previous curriculum focused primarily on the the WBAs, and while they did give a good structure for providing trainee feedback, they only assessed individual tasks. So the new multiple consultant report offers a more robust assessment of the integration of professional skills and behaviours and the performance of clinical and technical skills. And it does highlight the greater need for an awareness and engagement from trainees, potentially more training, although we can't say that there hasn't been enough available content and training opportunities at the beginning of the curriculum being launched. And finally, I'd just like to invite all of you to attend our Irish Surgical Training Group meeting tomorrow taking place. And this is the lineup. So thank you very much for that. And thank you, Chair. I'll wrap it up there.
Thank you very much, Michael, for giving us that important perspective. Sorry, Michael, thank you for that valuable insight from the trainees' perspective. We're just running a little bit behind time and the platform closes at 11. So I'm going to hand over to our next and final speaker, Professor Kevin Barry, who is the Director of the National Surgical Training Programme and is going to give us his perspective on the Iacp. Thanks, Kevin.
Good morning, Bridget, and thank you very much for inviting me to this session, and thanks to all the speakers up to now. And I've listened very carefully to all of the various points you've made, especially from the trainee perspective. So my title today, Reviewing Data and Information, the role of training committees in supporting training program directors. On the surface, they might appear to be three different and completely unrelated topics, but I hope to point out to you that there are very definite linkages between all of these various items as I go through my talk. So from the point of view of the first part of the talk, reviewing data and information, what I'd like to point out to you in this part of the talk is the sort of central role that RCSI has now developed in terms of the Department of Quality and Regulatory Affairs, and how in time to come this will influence decision-making about trainee performance and trainee allocation, and also more importantly supporting trainees in difficulty. So I'll talk about the role of the Quality and Regulatory Affairs Department, maybe give you some examples of sources data, and maybe practical examples of what I would describe as business intelligence and performance analysis reports, and also to highlight how all of this will feed into training committees and training program directors in the future with respect to quality assurance. So I think you'll understand that we're moving into a more sophisticated era in terms of our ability to capture data regarding training and to use this in a useful manner, not in a way to undermine any particular training department or trainer or training program director, but to help and to assist the process of improving the quality of training. So within the structures of the RCSI, we have a central department known as the Quality and Regulatory Affairs Department. It's not my intention to go through this entire slide, but just to point out to you that the Quality and Regulatory Affairs Department occupies a very central role from an RCSI governance point of view, and particularly with regards to training. So to the far right of the screen, the business section of this department, the blue arrow in particular will point you to the aspects that I'm most interested in, which is the business intelligence and the performance analysis reports. So from that point of view, business intelligence and reporting and performance measurement and analysis is an extremely useful tool from a training perspective. And this is something relatively new, and most people outside of the RCSI may not be even aware of this or that it exists. But it's important to point out from a governance point of view that the regulatory climate is evolving very aggressively worldwide, and there's an increasing focus on the quality of healthcare delivery worldwide. So quality becomes the center of everything we do. And within the Irish context, the Medical Council is the most important body in respect of the accreditation of surgical training programs. And most importantly, the data and information that we are now gathering and analysing will help to paint a picture for trainers and for training program directors. And all of this data will provide the opportunity to leverage or to use this data in a very supportive manner to inform decisions about trainee performance and opportunities for training. So examples of data that we are looking at, most of these you'll be familiar with already. We have the RCSI logbook report, which provides visibility to the level of activity of trainees on any training site. From the perspective of core surgical training, hospital-based directors can take advantage of this report to identify trainees in particular who are experiencing difficulty and to intervene accordingly. We also have access to a very useful tool called Power Business Intelligence, developed by Microsoft, and this is used to generate logbook data and all sorts of reports that are very useful in terms of analysing trainee activity and the performance of training units. As alluded to earlier by Michael and by Keith, the Iacp portal provides an enormous amount of data, and we're very privileged, and in a very good way we have the strong support of Helen Harty, who acts as our RCSI consultant in this area. We also use training post surveys, which are very useful to look at the feedback from trainees, and we also have previous reports from training post inspections. And indeed, we also very closely look at the performance of our trainees in the intercollegiate exit exams, so to speak. So from the point of view of practical examples of business intelligence and performance analysis reports, this is an example of how we use the CST Year 1 and Year 2 logbook reporting system. And this, if you like, can be used as a performance indicator. And if you see there to the right of the screen, the red column, that identifies underperforming trainees who for one reason or another have a logbook score that is below that which we would regard as satisfactory. But this type of data is important insofar as it can be used in a constructive fashion to identify the training needs of trainees who require extra support. So we're in a position to provide this data to training program directors and trainers, but to use it in a very sensitive and constructive manner. Here is another type of business intelligence report where we look at hospital-specific reports relating to, again, logbooks. But the intention behind this, of course, is not to present this as a league table to undermine any particular training unit, but over time to analyse the variation in training activity in the hope that we could reduce the variation in the training activity and to monitor training activity across all of our training sites nationally, and to hope that over time that there would be a greater level of consistency in terms of trainee performance and training activity with less, if you like, deviation from the mean. And here again is a more sophisticated example of a business intelligence report on the M-Surgery portal. This provides a greater level of sophistication that sits on top of our logbook e-system, and it pools data and runs data together on, as I said, the Microsoft Power Business Intelligence platform. Power Business Intelligence is an interactive visualization software program developed by Microsoft, and it has a primary focus on business intelligence. And of course, we can use this to provide all sorts of data. It's somewhat similar to the National Office of Clinical Audit insofar as we're at a stage in surgical training where we can delve into training activity in much greater detail. And of course, the purpose of all of this is to provide this information in a constructive fashion to the training committees and the training program directors. So the role of the training committees in all of this and in terms of quality assurance, well, there's a greater structured approach being developed by training committees when it comes to quality assurance. And for every training committee meeting, this becomes a standing agenda item regards to quality. And we're particularly careful now with regards to our interactions with the Medical Council when it comes to medical council accreditation of training posts and in terms of performance measurement and analysis. So what we're trying to encourage is a continuous improvements culture and using the type of data that I've shown to you to inform decisions around training. This is all built around collaboration and support, and it's essentially taking advantage of the available business intelligence in the RCSI Surgical Affairs Department. The training environment per se, the agenda has been set for the remainder of this decade, and the main forces, if you like, are summarized on this slide. We're moving into an era, as you've heard before, relating to the expansion of surgical training numbers in accordance with the National Doctors Training and Planning Unit, and also with regards to national health policy. Also, we're looking at expansion of the international medical graduate programs, and as you'll hear later today, we're also looking at developing structured educational supports for doctors who are not officially assigned to training programs. And this is a slide from the NDTT report entitled Demand for Medical Consultants and Specialists to 2028 and the Training Pipeline to Meet Demand. I'm not going to go through this slide in any detail, but just to highlight to you that these are the market forces, if you like, that we have to respond to in time to come. And our role, if you like, is to train surgeons who are fit for purpose and fit for the needs of society, and also to encourage a more equitable distribution of surgical expertise across the country in the years ahead. The NDTP have looked at medical workforce planning with regards to all training bodies, and closely interact with all of these stakeholders, most especially the Medical Council of Ireland. The Medical Council has come back to us, to the RCSI, and this is important from the point of view of trainers and training program directors. In September of 2021, the Medical Council issued a number of recommendations, particularly highlighted here, that all trainers must be appropriately trained for their roles. And this can be achieved through courses such as Train the Trainers course, and should include specific training on trainee mentorship and communication skills. And most importantly, the need to provide protected time for training program directors and trainers to enable high quality delivery of surgical training programs. So the Medical Council have come back to us with a draft of standards around this area. And I guess with our role in advocacy and our interactions with the Medical Council, what we would like to see over time is that these recommendations would become, if you like, formal standards and would be adopted in legislation by the Minister for Health, because they're relevant, particularly in the context of the expansion of training programs. So how do we intend on tackling these recommendations from the Medical Council? We're continuously in conversation with the NDTP with regards to increasing the funding stream to accommodate increasing training numbers. We promote the professionalization of surgical training. We advocate for the protected training time for trainers and trainees. And what we're looking for is a weekly session allocation in terms of time, protected time for program directors. So the agenda going from July 2021 to July 2028 is to significantly expand the national surgical training programs. Currently, we have, as of July 2021, between core surgical training and higher surgical training, we have 383 surgical trainees on postgraduate training programs across 11 specialties. By July of 2028, that number will have increased to 520 or thereabouts, representing a 36% increase in the number of surgical trainees on training programs, and closely matching the NDTP request to increase training numbers by this amount. And this is very closely allied, if you like, to the expansion or the projected expansion in consultant workforce requirements. If we are to expand our training programs to this level, this will have a significant impact on the commitment and the buy-in from both trainers and training program directors. Our training committees internally consist of the Core Surgical Training Committee, which is held up by Derek Kavanagh, and it meets 4 to 5 times per year and is responsible for all aspects of core surgical training. Then we have the specialty training committees, which are involved with the running of the higher surgical training programs across the 11 training specialties. And both of these committees feed into the Irish Surgical Postgraduate Training Committee, which is the central body that, if you like, is responsible for all training activities within the RCSI. With regards to external committees, we have the ISCP Management Group, and I represent the RCSI on this committee. Then we have the JSCT, the Joint Committee on Surgical Training, and I also represent the RCSI in this committee. And then we have another external group, the Intercollegiate Specialty Accreditation Committee Group, Specialist Advisory Committee Group for all of the 11 specialties. So there are many committees involved both internally and externally, and all focused on training, and I sit on most of these committees. With regards to specialty training program directors, we have 11 training specialties as shown on this slide. And for each of these higher surgical training programs, we have a specific training program director. The role of training program director is critical to the quality of the training programs that we deliver, and training program directors in many respects are the unsung heroes in all of this. They have to meet certain criteria, both essential and desirable, as outlined in this slide, and particularly have to have training in equality and diversity, and training in appraisal and giving feedback. In addition to that, they have to have in-depth knowledge on training and selection methods, and awareness around issues regarding trainee performance and trainee progression. And they also have to have excellent organizational skills, excellent communication, counseling and liaison skills, and problem-solving abilities. So all of this is, if you like, placing significant demands on training program directors who, by the very nature of things, occupy very busy clinical jobs in their own right. And the responsibilities of the training program director for each of those 11 training specialties is very, very significant. And particularly, we would point out that there are 8 roles here, and I'm not going to go through each of these in detail in the interest of time, but you can see, for example, along the top row there, that training program directors are responsible for appointments to the training program, the overall structure of the training program to be delivered to each trainee, rotations, placements, attachments, including spending time out of program, accommodating needs of trainees wishing to work less than full time. So the training program directors have a hugely responsible role to play. And with the expansion of the national training programs, the numbers of trainees across all of those 11 training programs will increase significantly. So it's absolutely necessary that training program directors are recognized for their efforts. So finally, what happens in the UK? Well, in the UK, the training program directors get a time allocation for their role, and essentially the employing trust of the training program director allocates a sum of money to provide for protected time in order to support the educational work of the training program director. Depending on the size of the training program, if a training program director is responsible for more than 40 trainees, that training program director gets a weekly allocation of 4 hours of protected time to carry out that duty. If the training program contains less than 40 trainees, that training program director gets 2 hours of time every week. And during that training time that's protected, the training program director has no clinical commitments and also receives administrative support provided by the trust. So that's the position in the UK at the present time. And I would hope that with further consultation with the NDTP in particular, with the expansion of the training programs and with our interactions with the Medical Council, that over time that we can develop a protected time for training program directors and for trainers. So finally, I'd like to acknowledge the help and support in putting this presentation together from our senior registrar, Ms Sandra Hembrecht, who's working with us at Mayo University Hospital, as always to Helen Harty, who is our RCSI consultant for the Intercollegiate Surgical Curriculum Programme, and to Emeka Okereke, who is our Senior Quality Assurance and Compliance Specialist at the RCSI. So I just wanted to give you an overview of where we're at the present time in terms of generating data and how we chart the next 7 to 10 years. Thank you very much.
Okay, thank you very much, Kevin, for your talk, and thank you to all our speakers. I'd just like to open this session for any questions. If anybody has questions they'd like to ask the speakers, you can raise your hand, and you should also be able to submit the question in writing. I can't see any hands. Keith, I'm just going to ask you, you mentioned the timing of the MCR you felt maybe could be maybe changed because of the engagement after it's been completed. Do you think that's the biggest learning point from it to date?
Well, not necessarily the biggest point. It's just, I mean, certainly as a training program director, previously I'd always felt that you noted lack of engagement with the Iacp after the ARCPs in a placement. And the point I was making about the MCR really relates to linking it to ensure that at ARCP there's as much valid information to allow the trainee to progress from placement to placement, more importantly from year to year. And that one of the problems in the UK is some of the ARCPs, they are controlled by the deanery and they occur at different seasons. So it's quite common for people to have ARCPs in June or July when their placements are finishing at the end of September. And that means that they're really out of sync with the valid MCRs. And so we've had to look at developing some workarounds. So an example would be, say, in orthopedics in London, they were arranging to ARC people quite early after appointment, so to almost have an introductory meeting. But that meant that they made the ARCP slightly out of sync, so that they always followed a significant MCR, and that MCR could be looked at by the panel, and they'll have access to it, and that allowed them to progress on well. And so we think that that's what we really mean about the timings and the workarounds, and it means that all time in training is valid and utilised appropriately. I would just a question was asked about the critical progression point table in one of the talks. I should have made it clear that the critical progression point table I showed was for vascular surgery, which is why the number levels were different. The critical progression point tables are specific or slightly different in the specialties, and people just should be aware of what their specialty levels are.
Okay, thank you. Owen, you had, I don't see any, oh, there is some questions just coming in here. As the trainees would like more support from the IACP, does the IACP have any further plans for supporting trainees, or would you like to respond to this in any way? Kevin, I'll maybe hand that over to you.
Yeah, I think that's a very valid point.
Kieran has,
yeah.
If you'd like to say a word.
Yeah, I think that's a very valid point that Michael in particular has raised, and I think that's something we can work with Helen Harty. I think from an RCSI perspective, we're very fortunate to have Helen Harty, as well as having Keith's support as well to the IACP. But I think definitely, as Michael has raised this through his survey, I think we can respond to that. And I think that's part of my role, is to be responding to the needs of trainees. And so definitely with Michael and his team, with the ISTG, we can certainly look at ways and means by which we can help the trainees as they adapt to the new curriculum. And this is a transition period for everybody. And as Michael pointed out, it would appear from Michael's survey that the trainers as well will need maybe some extra support as well. But I think we certainly have the ways and means within the RCSI of you know, assisting the trainees and the trainers. So certainly there's work to be done, and that's what I've picked up. That's the message I've picked up from this morning's meeting.
Okay, thank you. Yeah, and I think that question has been raised again about extra sessions for the trainers. Keith, I'm going to give the last word to you.
Oh, yeah, no, thanks. What I was going to say, and this sort of feeds back to some of the excellent points that Michael made. From the ICP point of view, we're going to produce a webinar dealing with how to prepare for your ARCP related to the new curriculum, so that will hopefully give a lot more information of how to deal with the issues that Michael raised, such as the administration of your own portfolio, how to get the most out of it, how to represent things well within your portfolio, and how to prepare for your ARCP. And we're going to do that for trainees and trainers as well, so people are aware how to assess the portfolio when looking at the trainees. So hopefully the feedback from that will be that trainees will feel that it's a much more meaningful assessment, and it represents their activity with greater clarity than was expressed in the survey.
Okay, so I would just like to take this opportunity to thank everybody, to all our speakers this morning, to everybody for taking part. Michael, thank you very much for giving the trainee perspective, and I think that shone very important light on the situation. Thank you to everybody who joined us online, and I know there has been some technical glitches, so I apologise for that, and I'm just going to close out the session now. Thank you to everybody. Thanks, Keith.
Yep.